for your talk.
Hello, welcome to this lunchtime session. This is great that we have some people coming and foregoing actually lunch to be here. So welcome, I'm Sabine Kleinert from the Lancet. And what we are going to do in this session is discuss, I think, 5 of the posters. This is the second such session. We had one yesterday, and we give each speaker about maybe up to 5 minutes to present their findings, and we can have some questions after each one. So our first presentation will be by Michael Kalmuselius from the International Federation of Medical Students, but he's also currently a medical student at King's College London, is that correct? Yes, and you'll be talking to us about the position of health in sustainable development negotiations, very, very topical right at this moment.
Is that working? Yeah. So we set out to basically undertake it as a group of medical students, take a review of where health fitted into sustainable development negotiations. It's something that we've always felt very passionately, that health and sustainable development are very closely related, but we wanted to see how in practice this fitted in, especially given that most of these negotiations take place outside of the health arena, outside of the WHO, often in New York, and are negotiated by ministries of foreign affairs. So we undertook a multitude of bits of work and basically have pieced them together here in this poster, kind of reviewing this. So the first bit of work we did was reviewing how health had featured in the run-up to Rio+20. And some of the methods that we used for this was particularly tracking the inclusion of health in each iteration of the negotiation text. And basically from the first draft, where there were 2 references to health, it went to health have its own chapter, and this was largely due to a big, over the 6 months that Rio was happening, a big push by those in the health community in actually educating negotiators on this. The second thing that we've done is that we've followed some of the post-Rio+20 processes because, Rio+20 mostly led to agreements to create agreements, notably the Sustainable Development Goal Open Working Group. And at this meeting, we decided, we had a team of students who came along, and we decided that we would try and see whether the negotiators were actually aware of the linkages between sustainable development and health, and we kind of surveyed them, and the majority of them actually saw the linkages. The only area that was perhaps a little bit weak is, well, 2 areas actually, were climate change and trade and technology transfer, and perhaps these are areas that there's going to be a need to be a big focus on in the next coming year to 6 months in the Open Working Group on Sustainable Development Goals for actually pushing around health and trying to educate negotiators on the linkages between these. The final thing we did, just because we decided that it wasn't enough to just look at the post-Rio+20 processes, is that we did a very informal kind of review of some of the multilateral environmental agreements, so some of the legally binding environmental negotiations and texts, to see how health was positioned. And actually, in the majority of those, health featured quite strongly. In fact, it was the actually stated purpose of the recent Minamata Convention on Mercury, so one of the most recent legal conventions on anything environmental. So all in all, I think our message is that health has featured in sustainable development negotiations. It has featured actually relatively strongly, and governments do, from foreign affairs ministries and environment ministries, do see the linkages, but there are still some areas that perhaps need working on and being made clearer, particularly around trade and climate change.
Thank you very much, Michael. Are there any questions for Michael?
So what we were doing for this piece of work is that we were following the negotiations in New York. For the survey, we surveyed 26 countries out of there were 69 seats in it, of which we got a full spread from low, middle, and high-income countries. But because we didn't have the full, every member of the Open Working Group, all 69 members, we couldn't disaggregate that data by country specifics. In terms of when we tracked the speeches, because that bit of the work we was listening to speeches, and that's something that we took notes on. We did notice that it did tend to be developing countries that linked climate change and health more than developed countries in their speeches, but that was something that was more anecdotal, kind of observationally listening to people than something that we formally measured.
Thank you very much.
It's now my pleasure to introduce Dr. Rupa Dutt, the past president of the International Federation of Medical Students Association. And Rupa will tell us more about her experiences in global health diplomacy, increasing the impact of youth in global health diplomacy, a multidisciplinary collaboration with a case study at the World Health Assembly. Rupa.
All right, thank you. So I'm going to talk a little bit about what we did at this last World Health Assembly. The International Federation of Medical Students Associations, IFMSA, decided that it was really key for young people to have the skills and tools necessary to negotiate and really have meaningful participation at the World Health Assembly. So what we thought about doing is organizing a workshop built on giving the skills for diplomacy, negotiation. So what we did is that we know there's a clear need. We need to educate youth participants about global health. There's streamlined actions for different youth actors around the world. And at World Health Assembly specifically, IFMSA has been an organization that's been going for a very long time. We've been considered one of the main NGOs in that setting. So what we wanted to do is really take this to the next level. What we did is we did a 3-day workshop. The methods we used were small working groups, panel discussions, and simulations where there was a lot of role-playing happening, where different people would play different roles. So there would be someone being a member state, someone being an NGO, someone being a participant, different actors coming together representing even the Secretariat being WHO. So students had the opportunity to learn how to actually interact in the World Health Assembly effectively. We had 42 students from 7 different disciplines. That was another key thing that we wanted to really explore. We've been talking a lot about intersectoral collaboration, multidisciplinary approach. So how can we really bring people together and share our skills? We had 18 countries represented, 5 continents, and we also tried to ensure that there was some global South representation, so we pooled together resources to have scholarships present as well. So these are just how we did it. We had some sessions at the World Health Organization itself, so getting to get the technical expertise. We also had academia represented, so we saw the perspective from the academic lens. Then we also had member states, different UN agencies present as well, so our participants got to see World Health Assembly from different angles and the perspective of health coming from all those different views. We focused on 5 different tracks. So the students were split up on 5 different areas: social determinants of health, human resources for health, research and development, sexual and reproductive health, as well as the post-2015 development agenda. And our outcomes after this is that we had a joint youth strategy. One of the things that we're asking member states to really take on is really adopt meaningful youth participation. A lot of other agencies have young people as part of their delegations. There's a youth forum that happens, but whereas at the World Health Assembly that doesn't exist. So what we did at the last assembly is ask member states to consider pledging and sponsoring a young person to be part of their delegation. We had 18 countries agree that this is something that they would really like to do. We met with also the regional directors of WHO, and 3 of them were very much behind this. And since then, IFMSA has also made a collaboration with PAHO and is in the works in collaboration with the Euro region. So for us, the youth strategy was really effective after we gained those type of skills. We also had a youth event at the World Health Assembly, and we had a dramatic increase in formal interventions. Almost at all the side events, we had a young person present, engaging, and participating. We had more interactions, and it has doubled to the point that we were, the year before, maybe reaching about 20 member countries. At this particular World Health Assembly, we had reached about 58 countries. I'd like to also say special thanks to the Graduate Institute, especially the Global Health Diplomacy Program, for being one of our supporters at the World Health Organization, and all the speakers. Thank you.
Thank you, Rupa. Are there any questions to Rupa at this point? No? I think then that's Sabine.
Can I have a question, please? I think this is a fantastic, new movement that is happening now. And you clearly engaging very much with the UN and the WHO, the international kind of organizations. Are you doing something also to bring back, that into your national strategies? Because this is where often I think the youth participation is hitting strong barriers.
So definitely with IFMSA's strategy, we really believe in thinking globally, but also really building capacity locally. So we have actually had this workshop take place at our last General Assembly, a different version which focused on post-2015 development agenda. We had another workshop on diplomacy in New York in March. And again, the focus there is how you can take the skills back to your home countries, how you can replicate it, and it's a part of our focus. What we wanted to do is that globally, especially in the health arena, there's a lack of structure for young people to meaningfully participate, and that's why we wanted to create this event and sort of sustain this, so we see that engagement globally too. Thank you.
Thank you very much. So our next speaker is Bernard Appiah. Bernard is a doctoral candidate at the Department of Health Promotion and Community Health Sciences at Texas A&M Health Science Center School of Rural Public Health in Texas, but he's also the director of the Center for Science and Health Communication, which is a non-profit organization based in Ghana. And Bernard will talk to us about interdisciplinary perspectives on culturally relevant communications to promote voluntary blood donations, a really, really important and understudied topic, I would say. Bernard.
Yeah, thank you so much. Please, how many of you happen to be blood donors? Cool, okay, thanks. Yeah, so basically this presentation is about blood donation in sub-Saharan Africa, but with a specific focus on Ghana, because I'm from Ghana. Yeah, the reason why I researched into this topic is because I wrote a story about blood donation in 2012. And by the way, I also happen to be a science journalist. And I realized that blood donation is a big public health problem in Africa because not many people are donating blood. And also, blood donation has huge cultural and communication factors that influence it. For instance, men in Africa think that when they donate blood, they will become impotent, for instance. So they don't want to donate blood. People also think that when they donate blood, the trait they have will be given to other people. So that if somebody comes from a good family, he thinks that blood should run between families and not given out to other people. So they are not donating blood. But communication, mass media is very popular in Africa, and we can use that to change some perceptions. So I wanted to see how communication and culture influence blood donation. So in this particular case, what we did were to use focus group discussions and then key informant interviews. Now, these are qualitative studies. The reason why we use this method is because it's a topic that is not well researched, and so we need to actually explore. So there wasn't much need for quantitative studies. We wanted to know what is actually happening. So we had 10 key informants, 4 journalists, 3 physicians, and 3 blood donors. And then we also have 2 focus group discussions. Now, each group had 5 participants. I want to say that those who took part in the focus group discussions were different from those who took part in the key informant interviews. And then we use qualitative data analysis software called NVivo to help quantify the themes that came out from the interviews and the focus group discussions. So in terms of the analysis, we're looking at communication channels, messages, approaches, and social cultural factors. So basically, in terms of the communication channels, the people we interviewed actually said, you know what, there should be a communication platform for journalists, for blood donors, and also for clinicians to come together and discuss these issues. And this could be a newsletter, it could be an annual meeting among the three. In fact, there was one physician who said that, you know, if you want to break barriers, it doesn't matter who you are, you should become a blood donor. If a physician is donating blood, if a journalist is donating blood, if a volunteer blood donor is donating blood, then you can bring all of them together. So, I mean, it was very important to consider these ideas. And then we also had the need to use social media. And here, you know, Twitter and Facebook is all over the place these days. And so there were some suggestions that we should consider using social media. And a very unique finding from this study is the suggestion that we should use a mobile telephone ringtones. Now, for those of you who are from Africa, you realize that ringtones happen to be very popular. When you call somebody in Africa, instead of you to hear a beeping sound like bing, bing, you may end up hearing something like a song or something like a message before the person picks the phone, okay? So there were some ideas to design interventions that will incorporate a song, a local song, or something like a message that when somebody calls, he will hear it and he will eventually become a blood donor. Now, the aspect of using radio or TV drama is also very popular in Africa. I mean, storytelling is quite popular in Africa. So there were some suggestions that we should consider using radio and TV channels. Now, so what are the socio-cultural factors here? If you use color tunes or ringing tunes of a mobile phone, it's not going to be in English alone. It can be either in English or local language. And that is a unique feature that is quite better than using only text messages, because those who don't understand English may not even be able to read anyway. So using a ringtone is more culturally appropriate. And then also, we should also consider using the mass media to celebrate blood donation-related milestones. For instance, people may have donated blood for the past 10 years or 20 years, and the media could just highlight that Bernard has been donating for the past 20 years, and he has kids. So in that case, those people who think that donating blood will make you incapable of having kids will know that, oh, it is not true. And then also, we should use social media to target the young blood donors. I mean, if you want to target adults, you don't want to use social media in Africa because not many of them are on Facebook anyway. So basically, these were some key aspects of what we found, and I just want to thank my co-authors who happen not to be here, Professor Imelda Bates in the Liverpool School of Tropical Medicine, and then Shirley Owusu in Ghana, and we have Alison Dunn also. So thank you so much for that.
Thank you. A really important topic. So are there any questions from the audience? Yes, please, Sam.
Yeah, it's a great study. I was wondering, because you face the same problem with clinical research in that people don't want to give blood samples. So do you think you could use the same strategies to promote participation in clinical research?
Yeah, I think that it's something, before this study, I did a systematic literature review of the role of culture and communication in blood donation. And the cultural aspect hasn't actually been addressed. So if somebody is not donating blood for those kind of testing, the cultural aspect could be that people even think that when you give your blood out, they are going to use it for witchcraft or rituals. So this is something that you can use communication interventions to make people know that no, it is not the case. But that communication intervention should be culturally appropriate. Because if it is not culturally appropriate, it will not catch them. Yeah, so these interventions could be used to hopefully persuade people to give out their blood.
Thank you very much, Bernard.
Now I would like to introduce our next speaker, Mr. Kofi Abubakar Muhammad, a public health physician from Nigeria. Abubakar is working for the National Health Insurance Scheme and will present his results on the understanding the barriers to the utilization of primary health care in a low-income setting and the implications for health policy and planning.
Okay, thank you so much. My name is Abubakar Mohammed Kurfi, as he said, and I work with the National Health Insurance Scheme. As a background, I just want to lay the foundation to the fact that in Nigeria, this study arose because we actually faced with some problems. The problem was that we had a mandate to ensure that all Nigerians were covered with National Health Insurance Scheme, with health insurance. But as at today, as I'm talking to you, only 7% of Nigerians are covered with the health insurance scheme. So we found out that there is a lot of problem. The problem is that people are not just using the primary health centers, which is the most basic level of care. So this study aims to find out why are people not using primary health centers in Nigeria? What else are they using apart from the primary health centers? What do they think is the solution to the problems that affect the primary health centers? And then the whole essence is to ensure that we link these findings to policy making so that at least that gap between research and policy making is filled, so that we can design interventions that will ensure that our people use primary health centers so that we can have a better coverage with health services. So these are the major challenges actually affecting primary health centers or primary health care services as far as Nigeria is concerned. We found that that level of care is assigned to the local level of governance, and that is the weakest and the least stable level of governance. We also found that it is heavily underutilized. Various studies have shown that between 5 to 10% of all of the people use primary health centers. It is substandard and of very low quality. There's a very poor linkage between the primary health centers and the other levels of care. It is vertical, it is fragmented, and it's also impoverishing in nature. Virtually everybody pays out of his pocket for health care, and of course there is gross shortage of manpower and infrastructures. This was the study location where we did the study. It was done in northern part of Nigeria, which is a place that is actually very heavily underdeveloped, low level of literacy, mostly subsistence agricultural farmers, and then we did a cross-sectional descriptive study. We now sampled about 630 households to find out from them what are the predominant health problems, what are the barriers to use of primary health centers as far as these locations is concerned. So the key findings we found is that most of the reasons why people do not use primary health centers is because of the lack of essential drugs. That's about 276 households out of 630 said there were no essential drugs. Then other factors that could affect were cost of services. And by cost here, we mean cost in terms of both the money you pay and the opportunity cost of going for primary health, for healthcare. Opportunity cost in the sense that people may boycott travel, their daily occupations, just to access healthcare. These are actually heavily poor areas. And then where did they go? To our very much surprise that 50% of these people go to pharmacies or patent medicine stores, which are just locations outside their houses where they are drug shops managed by artisans. So we're asking ourselves, how is it that people are more comfortable to go to a pharmacy than to go to a primary health center? And the primary center actually exists in these locations. And then other places they go to are the primary health centers. And then traditional doctors and spiritualists also take a very large chunk of the people. So we went ahead to find out what are the health outcomes in these locations, and we found some very disturbing statistics. For example, only 4% of the population deliver in the hospital. The place has a family planning rate of only 1% of the women have access and utilize family planning. 22% of the children only receive antibiotics when they have this. And of course, out of pocket for healthcare is 95%. Only 5% of the people are covered with any form of healthcare. And if you look at the availability of health services, you find out that only 19.0% of the population of the health facilities offer family planning. and growth monitoring only 57.1%. So this goes to show the degree of underutilization and lack of access to these services in these kind of locations. So what do you conclude should actually be the solutions is that we should introduce some element of public-private partnership in healthcare. We should also try to introduce some element of community-based social health insurance scheme that will cover the people, introduce performance-based financing mechanisms to encourage the staff to actually come to work, and then find a way to integrate PHC, traditional medicine, into governance. Thank you very much.
Thank you very much. Is there a question to Abu Bakr? Yes, please. Speak up very loud, please, because the people in the back won't be able to hear you. Or use the microphone, if you like.
I'll speak loudly. I just wanted to know that the barriers that you really pointed out were more from the provider angle. Were there any cultural or were there any other barriers that actually made people not access the facilities? Like, non-availability of drugs is definitely there, but a cultural process or cultural thought would also have been a part of the...
Yes, actually, if you look at one of the major barriers is a lack of drugs, but there are others like poor community involvement. People feel they are not involved in the way healthcare is actually being run. The government just comes from top, established primary health centers and go away. The people are not involved. So that's actually one factor that came out very obvious. Of course, then there's the lack of the distance between health facilities and the people. Socio-cultural factors actually played a very limited role as far as this study is concerned. We found that people are comfortable with the healthcare, but just they don't use it because of this barrage of factors. There are more provider-dependent factors than social or cultural factors. Yeah.
Yeah, thank you very much. Sabine.
I would like to now invite our next speaker, and that's Nasir Khan, who actually went to medical school in China, has a Master of Public Health from the Charité here in Berlin, worked in Pakistan, and is now again working in Berlin as an assistant doctor in the Clinic of Internal Medicine, Gastroenterology and Hepatology at the Charité Virchow. Nasir.
Good afternoon, everybody. I would like to present our study that's the barrier to accessing the German healthcare system for Pakistani immigrants in Berlin, Germany. It was a qualitative exploratory study, and the need of the study was very important. Here is the outline, that none of the study was conducted on Pakistani immigrants in past. If any, we couldn't find any in literature. However, the number of Pakistanis are 76,000 according to Federal Ministry of Interior in 2009, and this number is increasing year by year according to the same authority by 4,000 people coming into Germany. And the Pakistani immigrants comprise of an immigrant group which has different cultural background from that of mainstream Germans. They have different language. We are not speaking German or basically not English, but our national language is Urdu, which is totally different from that of German. And there was limitations which were never found and which was always discussed among communities, among Pakistani immigrants, but they need to be documented. That's why the study was conducted on this group. That was only one community center was taken as an example for exploring the barriers. So the main objective of the study was to explore the barriers to accessing German healthcare system for Pakistani immigrants. And methodology was chosen for the purpose as qualitative exploratory study. And in this study, according to Witzel 2000, he presented a problem-centered interview method, which is also called in some journals as semi-structured interview. In this method, generation of theoretical data is done by a study instrument, mostly a short questionnaire, interview guide, field notes, also called postscripts, and interview recordings. And after that, these recordings are transcribed and sorted. Different themes are sorted and coped from these interviews, transcripts. In this study, 12 participants were taken from in community center, and they have voluntarily participated. And this is the detail of our study, how it was gone through. And the result of the study was found, and a few of these results also confirmed the barriers which are already documented in many literature, many studies. For example, individual perception about disease, illness, and about healthcare system according to immigrants in that countries. Individual health-seeking behavior that is also brought up with the person, family history, or how they are brought up with schooling, and also the low literacy and language skill. Especially in this case is German. When people don't know good German, this could be act as a barrier. And illegal status of immigrant is one of the basic or important barrier to be mentioned that is always documented. And people with illegal status, sometimes they are served and sometimes they are not, but they are always hesitate to consult doctors or health setups. Co-payments and treatments cost not covered by health insurance or national health system play a very important factor as a barrier to access healthcare system. And in city like Berlin, though the cost and duration and complex connection between S-Bahn, transportation, buses, trains, and tram could act as a barrier for some of the people, not for everyone. And limitation of social system. The countries, like these countries and other Western countries, have very good social system, no doubt, but limitation of social system to provide health insurance cover is also very important factor that they can't help sometime, not always. And among that, we also found some new barriers which were never documented, never seen in literature. They are unfriendly attitude of registration staff, especially nurses or counter staff, towards immigrants. And this attitude is most of the time seen among patients, female with scarves or male with beard. And in this category, there is another category. There is other class like doctor specialist coordination, especially on patients' disease and their treatment. There was a couple of examples documented that prescription from specialist was rejected by a family doctor, which had impact not to visit the specialist again in future, that he was not very competent specialist. However, what was the misunderstanding? It was not clear, but patient was hesitant to revisit the specialist again. And there is another thing which is also very important factor, that is doctor-patient relationship, about discussing and about getting advice, and this also include the cultural understanding of communication between one thing and the other, how they are communicated and how they are accepted from the doctors to the patients. And the study was conducted in 2012, and from this study we got few of the recommendations that healthcare system and healthcare professionals should be adopted and trained to deal with diversity. That could be done by integration courses, training, translation services, hiring international staffs, visiting for a couple of months to other countries or other communities where they can have exposure to those people, especially not only for Pakistani, but the people in, for example, in some area they have quite a huge number of population of people, patients, which are served or which are visited by such doctors. They should consider their cultural background as well. An impact of healthcare cost burden on individual patients should be reduced by considering all incurred, for example, co-payments, traveling costs, medical services not covered by health insurance, and the quality of health care should be improved in terms of reducing waiting time for getting appointment and at clinics to consultations, strengthening inter-doctor, family doctor and specialist relationship, and promoting equity and equality. And here is a few references which were used for the poster presentation. Thank you.
Thank you very much. Questions from the audience to Nasir? I have a question then,
please.
if I may. You identified some very, very, very important points here. And one of your conclusions and recommendations was to train doctors or medical staff to be more culturally aware.
Yeah.
At what point do you think we should do this kind of training?
Yeah, that's the, for example, if I speak about Germany, then immigrants are normally getting integration courses. But most of the time, doctors are reluctant because of their busy schedule. They don't go to attend such integration courses. For example, a person coming from Africa, from far Asia, or from India, they have different backgrounds, and our institute, they should know what my patient is and basically what they want from their country and how, in what situation what are they expecting from us. They should be considered by a health profession, because it's about creating trust and how friendly you are with your patient. If you, for example, if you say a couple of words in beginning, for example, if we say here for Chinese ni hao, or for Indian ram namaste, and Islam for Muslim, then they feel friendly and they're likely to come and open up their hearts, what they are feeling and how they can better open up their disease and conditions.
Thank you very much. We should all go back and think about what we can do tomorrow, because these are very small steps that might make a huge difference that you've just identified. Thank you.
Thank you.
Our next speaker is Samuel Franson from the University of Oxford. He's a research coordinator for the Global Health Network, and in his final year of his PhD studies in Oxford. He has a Bachelor of Sciences in Biology from Nottingham. He worked in India, in Rwanda, and now in Cameroon and Ethiopia. And he will tell us more about the barriers and enablers of locally led clinical trials in these countries from his prospective qualitative study. Sam, please.
Thank you. So there's been a lot of talk about the barriers, so hopefully I can present some enablers as well, because I think this is the third topic on barriers now. But in 5 minutes, I'll try to explain really why this study is important, what the key findings are, and what we're doing. So, sorry. So first of all, why this study is important. The quote at the top comes from an Ethiopian investigator who took part in my study. And he said, "We don't have the evidence to change local practices, but we definitely know some written guidelines don't work." And the reason I included that was because it echoes many of the points from the Ministerial Summit on Health Research in Mexico in 2004. And really a decade later, we still have got a severe shortage of primary research evidence to guide policy, and the 1090 gap really persists. Part of the problem is that data from randomized control trials is really considered the gold standards for informing practice for most but not all interventions. And in lower middle income countries, too few trials are conducted. Research capacity remains insufficient, and most of the trials are run by foreign organizations. Now, why that's a problem is that we need both foreign-led and locally led clinical trials. Locally led trials are more likely to be responsive to countries' needs and sustainably link research to action than foreign-led studies. Part of the reason is they're more demand-driven, and also they tend to address issues like implementation research and also strengthen institutions, which allows them to participate more meaningfully in research dialogues. In 2005, the establishment of Africa-owned research centres capable of running their own clinical trials was identified as an international priority. But as you can see from the above quote, there's still a lot more that needs to be done to achieve this goal. We believe that finding better ways to support local investigators to lead their own trials is an important step to achieving this goal. So what's needed and what are we doing? There are very few peer-reviewed materials on trial capacity strengthening, and none of them are empirical. I'm doing a literature review, and I've reviewed 1,800 documents, 50 are on clinical trial capacity strengthening, and 3 address local investigator trials. So that gives you an idea of the literature deficit that we have. There are organisations which are doing well and building trial capacity in lower middle income countries, but really it's primarily to run international studies. There's little effort to boost autonomous trial capacity. We think that to be able to support locally led studies, you really need to understand the situation, and in particular, we need to understand what works, why it works, and in what circumstances. Our study is unique in addressing these methodological issues in this particularly neglected area, and we use qualitative methods to investigate the barriers and enablers to locally led trials in Ethiopia and Cameroon, and we're also conducting further work in Sri Lanka. We take a bottom-up approach and engage with stakeholders who deal with the problems on a daily basis, which allows us to capture both tacit and explicit knowledge. Stakeholders include researchers, students, administrators, ministers of health, ministers of education, and also the main medical research institutions. We present findings in a systems perspective and propose enabling practices and make recommendations. So what are some of the key findings and recommendations? Well, the good news is that trial capacity exists, and in isolated circumstances, they're doing a very good job. The problem is that there's barriers throughout the research system which are actually quite similar within both countries. However, there's specific issues in leading research which are beyond those normally encountered by trial teams working on internationally led studies. And what that means is for people who've worked on internationally led studies, it doesn't necessarily mean that they're equipped to run their own trials. Those issues tend to be context specific and really would require a locally tailored response. So we'd argue that to support locally led studies, funders need to move beyond the project-specific capacity strengthening, which really places the research output as the primary evaluative goal. And instead, what you need is a separate capacity strengthening where the output is really the capacity to run locally led studies. In particular, there's need to make fundamental system-wide changes to develop national research systems. There needs to be a considered and dedicated package of enablers designed to harness capacity to undertake sustainable, locally led trials. And really the final takeaway point is that if we want to make this laudable goal of Africa-owned research centres capable of running their own trials a reality, we need more data like this and more implementation research and more research systems research. So I'll just leave you with a quote from the International Commission on Health for Research and Development. Thank you.
Thank you very much, Sam. Are there any questions to Sam at this point, please?
Yeah, I mean, that's a very good point. I mean, from the start, we did take a bottom-up approach because we wanted to engage with the people and understand why they weren't doing it. But you're right. I mean, obviously in 5 minutes it's hard to present all the findings, and hopefully you can take a look at my poster at the back and we can talk about it more. But political commitment and recognition and incentives and funding is a huge issue, which they bring up a lot. But in terms of what this can do is, I think the political commitment is only going to come from advocacy from investigators and from researchers. And actually very often now, the researchers are moving more into politics. If you look at the Ministers of Research, the Ministers of Education, they've often had some degree of research background later on. It's starting to come. Very often at the minute they don't understand it, and they don't value it, which is a huge problem because this research is undervalued. But I think the only way it's going to get valued is you have good advocacy from local researchers who can show that they're doing good research. And it's the whole chicken and the egg. Policymakers are not going to value research unless there's good research, but there's not going to be good research unless policymakers fund it. Yeah.
It's a vicious circle, which is going around and around.
And I think one...
You cannot have a really good trial if you do not have a good funding, so who's going to fund that? And it's the same story that we were discussing in the morning session as well, that the research is really driven by funding. Because we have seen a lot of HIV research in the last years because it was driven by funding. So whenever there is a funding, there is a research. And research is always driven in the direction where the funding, where the money is going. So
Yeah, what I would say is there's some very good examples of people doing some really good research, including clinical trials, on a very low budget. And when I say clinical trials, it's a broad term. I also mean randomized control trials. So one great example was one in Cameroon, where they used text messages to send to people to remind them to take their medication, particularly for ARV, and it was later rolled out for TB. And it was a really great project, and it had very minimal funding, so there's some really good pragmatic studies, if they're well designed and well thought out, can be done with a small amount of funding. And I think now there are some funding streams opening up. I know it's still international funding, but one of the TDR streams that's just opened up was the £50,000 grants for the TDR scheme that a chap was just talking about. So it can be done, but it's very tricky. So I do agree with you, yeah. And I think that does.
Thank you very much, Sam. I'm sorry we're a bit running out of time. We have one more speaker. Maybe the two of you could link up later for a cup of coffee and discuss it. So, Sabine.
Do we have Dr. Figueiredo Augusto in the audience? Great, so please come up. This is our last speaker. Dr. Figueiredo Augusto is a Master of Public Health student at the London School of Hygiene and Tropical Medicine and a PhD candidate in International Health at the Institute for Hygiene and Tropical Medicine in Lisbon, where he also graduated from and is currently a registrar in public health. And he will talk to us about prevention of mother-to-child transmission in Angola. Thank you.
Yeah, the big...
Yeah.
Right. The poster is about prevention of mother-to-child transmission in Angola. Angola is a very specific country in West Africa. The civil war, the long-lasting civil war in Angola just ended up in 2002. And several studies suggested the civil war could have been some kind of a protective factor regarding the HIV epidemics. But since the war is over, a new window of opportunity to control the HIV epidemics in the country was opened. There is an estimated population of 20 million people in Angola. I say estimated because the first national census is taking place right now, between July and September 2013. And the estimated prevalence in 2012 was 2.3%, with 250,000 people living with HIV. However, in 2010, a UNICEF report was published and identified several countries, most of them in sub-Saharan Africa, where 90% of pregnant women infected with HIV were living. And they identified 22 countries in the world, and one of them was Angola, with an estimated number of HIV-positive pregnant women in 2009, 16 thousand. So Angola was targeted as one of the 22 priority countries of the global plan to eliminate new infections in children and keeping their mothers alive by 2015, which is a very long title. And so this research wanted to do some evaluation of what is the progress, not only since 2009 when the 2011 when the global plan was launched, of course, but since the PMTCT, Prevention of Multi-Type Transmission program, was implemented in Angola. Though the program was implemented in 2004, we just conducted analysis between 2005 and 2012 because data from 2004 were not very consistent. So we analyzed national level data from PMTCT, and we selected these indicators because were the indicators with data for all the entire study period. Some other indicators could have been added, and very important ones like the number of children receiving antiretrovirals, but we didn't have data for 2011 to 2012. However, this analysis was included in the original paper. And we conducted our analysis on these 5 indicators. First of all, the number of PMTC sites in Angola had a remarkable progress since 2004. When it's not here 2004, they opened 3 units in 2004, then 9 in 2005, and in 2012 they had 347 antenatal clinics delivering PMTCT services. Our estimation says that in 2015 there will be 584 antenatal clinics with PMTCT services. However, the national plan for elimination of HIV transmission from mother to child in Angola set as target for 2015 800 PMTCT sites. So this number can improve, a bit closer to the 800, but well, it's very unlikely that the 800 will be achieved. The proportion of pregnant women tested, we calculated these percentages, these proportions, using the estimated number of pregnancies in the country. And we see that since the PMTCT services were implemented, there was an incredibly big progression of testing women. They test more and more as they open more and more PMTC sites. However, only in 2012, only 33.7%, which is much better than in the beginning, of course, but still around 70% of pregnant women that are not tested for HIV in Angola. And we also predict that not even half of them will be tested in 2015 according to this trend line. The proportion of HIV-positive pregnant women, only among those who were tested, of course, so those identified in PMTC sites, was declining during the study period. However, quite concerning estimation, the number will be 2.8% in 2015 because the line, according to this trend line, it is shifting, so it's quite rising a little bit during 2013, 2014, 2015. Of course, we do hope the trend line to be a little bit more optimistic in 2015. And finally, the proportion of HIV-positive pregnant women who received antiretrovirals, and this is very, very, very crucial data from our analysis. The proportion of pregnant women that received ARV was declining during the study period. Despite the incredible progression in PMTC sites, the incredible progression testing women, it seems that Angola has a very limited capacity to include those women identified as positive receiving antiretrovirals to prevent the transmission to their child. So, and for 2015, we predicted around 39%. Only 39% of those identified in PMTCT care will be receiving antiretrovirals. In our original paper, we also included, because these are the women that are identified in PMTC sites, but if we consider the estimated number of HIV-positive pregnant women in Angola, for 2012, the percentage is 17%. So only 17% of the estimated number of HIV-positive pregnant women in Angola are receiving antiretrovirals. So, main conclusions, of course, Angola is very unlikely to meet the global plan goals by 2015. But more important than achieving those goals, there is urgent action the need of an urgent action to scale up PMTCT in Angola. And last year, in July 2012, Angola launched the national plan to eliminate mother-to-child transmission, and fortunately they could include the First Lady of Angola as a patron of the plan, so there is some political will here, and we do hope the plan will shift this trend, to change this trend, to improve the results in the upcoming years.
Thank you very much. I mean, great achievements already, but a lot more to do, which, as you have summarized. We have unfortunately run out of time for questions, so let me just thank all our speakers and you as the audience to actually, you know, I'm very grateful that you gave up your lunch break to be here and share with us these data, you know, real data, what is actually happening in countries, which I think we should do a lot more in meetings like this. Thank you very much.